أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم نحمده ونصلي على رسوله الكريم سبحان ربك رب العزة عما يصفون والسلام على المرسلين والحمد لله رب العالمين رب يسر ولا تعسر وتمم بالخير رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي صدق الله العلي العظيم. Well, in the chemotherapy, you have gone through different antibiotics, and after that, number of antibiotics they are also, some of them, not all, they are used here to treat tuberculosis. You know, tuberculosis is something, a very important disease, and about this mycobacterial disorder you might have gone through in your pathology department. Tuberculosis. Some of you may be familiar with this disease, and you know the main organ involved, you know it is, and these are the lungs, pulmonary tuberculosis. While number of other organs, they are also involved, and none of the organ is spared by it. So those organs other than the lungs, there may be meninges, it may be brain, gut, liver, it may be of the kidneys, and disease of tuberculosis of bones. So anyhow, all the organs are susceptible to this bacteria. Tuberculosis, it's a worldwide problem. There is wide distribution in the world. No geographical part of the world is spared by it. According to one stat, around 10 million people, they suffer from tuberculosis in 1 year. As regards the distribution and which are the most 10 topmost countries where it is more prevalent, which are more affected by it. So these are among the top 10. Luckily, our country is at position 8. So which of the countries is most affected? First one is the India. So for that very reason, Indian scientists, they have worked a lot on this disease, and they have their own regimens to treat it. Then after India, it is China, and also other countries like Bangladesh, South Africa, Nigeria, Indonesia, like that. Anyhow, luckily we are at position 8. When this tuberculosis was disclosed around 1850s, so at that time 1 out of 4 patients, he or she used to die of the disease. Anyhow, progress to treat it, it remained in process. So you might have heard about the sanatorium. What I remember, there is one in around Murray. So it was decided that the patients suffering from tuberculosis, they be they be shifted to some healthy place where there is no pollution. They be given good diet and proper environment. So sanatorium they were made. They were kept away from others. Then drugs came into process. So among the initial drugs, one is the streptomycin. You know, it is aminoglycoside, and in detail you have been taught by Professor Said Anwar Saab. And people worked on this streptomycin. I remember 60 years back, these injections were there, streptomycin. It was combined with uh, penicillin. The injection was known as symbiotic, and this injection was distributed among the people, and they were asked to get it. So this was one of the important medicines used. Another drug discovered in America, this was isoniazid. Isoniazid. You read shown about it. Isoniazid is a hydrazide of isonicotinic acid. Isonicotinic acid. So number of other drugs which came in the process, and it was found that one drug is not sufficient, and drug resistance that appears very rapidly for the reason two or three, even more, up to four drugs given, multi-drug treatment was given to avoid the emergence of resistance. So about the diagnosis side, different procedures they are adopted. I mean, laboratory tests are there, X-rays are there. I remember one X-ray machine that was taken to different villages of the country, and screening was done over there. Are the lungs clear? And that was compulsory at that time, say around 1960s. Compulsory that way. Another thing what was done, that was the BCG vaccination. Bacillus BCG, Calmet Curin vaccination, that was also done. Another thing which was tested was the tuberculin test. Mantox test, like that. So number of approaches were there to diagnose it and to treat it. So in the lungs, the typical picture was that of opacities in the apical area, apical opacities, apical infiltration was there. Then symptoms and signs, high-grade fever. There are two types now. One is symptomatic tuberculosis, other is asymptomatic. One is frank and the other may also be known latent. So it may become dormant. Tuberculosis, something very strange. It remains dormant for some period and again appears. So tuberculosis that was that is treated with number of drugs. I mean, we were talking about the symptoms and signs. So what happens? Most common symptom signs, they are cough. According to one information, if the cough is for more than 2 weeks and it is with expectoration and it is with fever, sweating, weight loss, so there are more chances of tuberculosis in general when the cough is prolonging. So it must be investigated in detail. So these are the common. Then there may be pain in chest. There may be hemoptysis, blood in the sputum, and that sputum was also tested. Is still tested for acid-fast bacilli, and based on acid-fast bacilli, the treatment schedule is applied. So it's something about the general introduction about the tuberculosis. As the resistance developed and due to the incomplete knowledge how the drugs act, so great emphasis was given to it, and the biggest problem to treat it was the resistance, bacterial resistance. And usually when the temperature subsides, say in 1 or 2 weeks, patients, they used to leave the drugs. So again, there will again be temperature, weight loss, cough, hemoptysis, like that. So resistance remains the problem. For that problem, at the WHO level, one program is there known as DOTS. DOTS, note down this, please have a pen and a copy where you DOTS program, directly observed treatment short course. So the government is responsible to treat a person, diagnosis, to give drug, to supply drug, and to monitor. A number of things is done by the government. DOTS program is there. Another program is TB alert. So it is in other countries, TB alert. So why it was emphasized? You know, it is the coughing. So communicated a general way of communicating disease from one to the other. Sneezing, coughing, droplet infection is there. So it's mainly a disease of poor environment, slum areas. So in advanced countries, they also work on this side, that the houses be of proper shape to have proper sun. Another thing why it was emphasized to treat it, the drug resistance, there was another reason. It was the intracellular location of bacteria. Intracellular location of bacteria, so it remained problem. Another thing related to this tuberculosis, it has got chronic nature. I know ladies suffered from this tuberculosis, and it got dormant for some period, and they got children during that time, and like that. So next thing about tuberculosis producing problem is the patient compliance. You have already been told that people, they leave aside the medicines as they feel well. Non-bacteria, and the main one for tuberculosis is the Mycobacterium tuberculosis, And second, it is leprosy that produces leprosy. And another one is Mycobacterium avium intracellular. Well, this was a brief introduction about the tuberculosis, and then we come to the next slide. What is our purpose? What is our objective about the tuberculosis? At the end of the lecture, you should be able to know to which drugs are known as first line. I mean, they have acceptable toxicity and they are very effective. First line, they are very efficient and they have acceptable toxicity. First line drugs. And you should also know few drugs known as second line. If the resistance is developing to first line, then the second line drugs, you should be able to enumerate them. And then this is one very common question. What is the rationality of using a combination? You know, it's the emergence of resistance and that appears. So a number of medicine, they are combined together. And as the treatment is for a longer time, for good time, say 6 months, 9 months, even up to 18 months, so one has to be very careful about the toxic effects of these drugs on different organs, like especially the nervous system, the kidneys, and the liver, like that. Their toxicity must be kept in your mind because the treatment is very lengthy. And few regimens may they be in your mind. What's the first regimen? How many drugs be given first, and then how many drugs be given later on, and like that, and change and culture and sensitivity. It must be done, say after 3 months. So for proper treatment. How the drugs act. Usually unknown mechanism is there, but even then now the scientists they have worked on at the genetic level and how the drugs act and how resistance that develops. How the resistance that develops. It's something very important in this case why the resistance to tuberculosis is there. So you have already been told about it, the major causes why the resistance is there. We will also enlist them and we will revise over here why the resistance that appears. So then coming next, how to use these drugs. What is there? Even the dose is very important about common drugs. These isoniazid, streptomycin, route of administration, rifampicin, a very common drug, rifampicin, and other like ethambutol. So the clinical uses. Some of the drugs are particularly indicated for this tuberculosis, while some drugs they have so many other applications. Drugs are not given only to treat tuberculosis, but also in susceptible areas they are given for prophylaxis. And again, their toxicity is very important of the individual drugs, and we are not to give these drugs. It's also important. So, you know, there are departments, there are tuberculosis wards, there is awareness work for tuberculosis, and at the world level it is being done to control it. Luckily, in 1960, it was declared if you give a combination of medicines, and then it was declared that it is 100% curable, and it was. I do remember. Then about their drug resistance, it appeared in around 1970 started appearing, and different regimens they were tried. Coming to the next picture. There's something about the bacteria. You have been told that different bacteria there. One is the Mycobacteria. Over here it is written that it is resistant to most antibiotics. Reason being, it is intracellular and it resides within macrophages. Mycobacteria intracellular and resides in macrophages. And this bacteria is inaccessible to drugs that penetrate these cells poorly. Cell wall penetrating is something very important. So the drugs they pass through the cell wall and how they work will be taught about. Another problem why this bacteria it gives resistance. It is the lipid-rich mycobacterial cell wall. Lipid-rich. The cell wall, you might have heard about the mycolic acid, one part of that. Also other important constituents of the wall material. Lipid-rich mycobacterial cell wall is impermeable to many agents. So it's something why the resistance is there. Few lines are given. Another thing, these bacteria, they grow slowly in general. While the antibiotics, they are effective more effective against the rapidly multiplying bacteria. So this bacteria, it grows slowly, and the antibiotics which are most active against growing cells are relatively ineffective. Very important. Because of its slow multiplication, so the antibiotics are not very effective. And another thing you have been told that is dormant tuberculosis is there. So the dormant cases, they are completely resistant to many drugs and they are slowly killed. I mean, the treatment is for months, even for more than a year, you have been told. So resistance is something very notorious. Resistance. Then to avoid this resistance, you have been told that 2 or more drugs or even up to 4 drugs are given. Response to the chemotherapy or this, it is also slow and treatment be given for a very long period. Next. Tuberculosis. Here you see a person coughing and it is communicated. On right picture here you see the emaciation, weight loss. So the people I remember in army, they were given very high protein diet. Here you see a person, there is wasting. So wasting, weight is measured say after a week or 15 days like that. Medicines were given say for 15 days. And over here, you have been told that it is tuberculosis, Mycobacterium tuberculosis is the main bacteria and the bacteria for TB. And then latent TB, it is asymptomatic. It doesn't spread to others. Latent TB, it remains silent. As concerned the incidence, beautifully given, one third of world written over it. But I have gone recently that say 10 million people in world this a year they suffer from this. Written over one third of world population is infected. Maybe it is from some literature. Anyway, in 2014, you know these slides are collected by your also the teacher, Dr. Pracha. She organizes it, then I discuss it with you and add some few things. In 2014, there were around 9.6 million cases. Here, it's just like that, say 10 million, around 10 million I was telling you. 9.6 million cases of active TB. So the deaths were 1.5. You know 1 million and 10 lakh. So 15 lakh deaths were there. And where the deaths occurred, these were the developing countries you have already been told. And the main is the India and China, Bangladesh, like that. Then we come to the general signs, symptoms, you've been told about it. Cough is there, fever, chills, night sweating is also important, weight loss, appetite loss, and fatigue. So about the basal calmette cure and vaccine, you have been told. Another program dots. If the S is added, it is short course. Directly observed treatment. Government takes good care of the patient. So, which part is more infected? You have been told that these are the lungs commonly infected, or the lungs, and any other part of the body may be affected by it. Again, the sign symptoms are there, given over here. Next, main part is these are the lungs, which is the may infect any part of the lungs or the main. Next, may be pulmonary and it may be extrapulmonary. Other than the lungs, other different body parts may. Okay. And there, here you see at the lower line, there is World TB Day. As you see, Husband Day, Women Day, Teacher Day. It is World TB. 24th March is the World TB Day. So for awareness, walks are being organized. So one of the this chest physician, he was telling years back that it is the medicine which is more important than the food to treat a patient. It is the medicine which is more important than the food to treat a patient. I still remember the patient. They used to be emaciated, weight loss. I mean, even there was no muscle mass where the injection could be given. At that time, streptomycin was the main thing, and the only route was the intramuscular streptomycin. You have gone through it in detail. Next. It's one picture given over here. A patient of tuberculosis. So is tired and there is anorexia, weight loss, there is chronic cough. So in the result of this tuberculosis in the lung, there may be opacity, there may be cavities they are formed in the lungs. So these are the symptom signs given over here, left side. The night sweating is also from. Then blood in the sputum, pleuritic chest pain, very important, and maybe low-grade fever, or initially maybe high-grade fever. Next, how the drugs they are classified. First line, why first line? I mean, you have been told they have greater efficacy and their toxicity is acceptable. So here you say now the sequence has changed. History-wise, streptomycin was first there, and you know streptomycin obtained from Streptomyces griseus. So then isoniazid. This is one classification. Isoniazid not only for the treatment but also prophylaxis. Similarly, rifampicin not only for the treatment but also for prophylaxis. Not only prophylaxis of the tuberculosis, even for some other against other bacteria uh, to avoid the infection. Like rifampicin, pyrazinamide, it is like ethionamide or isoniazid. You have been told that isoniazid, it is hydrazide of also nicotinic acid, nicotinamide. So that's then pyrazinamide, then ethambutol, it is synthetic streptomycin. Second line, what drugs were given here? Number of drugs obtained from, they are from the group aminoglycoside. Aminoglycoside, streptomycin family. So changes, they were, you may say that in the basic structure or family of streptomycin sharing similar structure, pharmacological aspects, and toxicity. In the second line, when you see resistance is there, so other drugs they may be added. Here you see second line, first one amikacin. It is like this aminoglycoside, streptomycin family. Then aminosalicylic acid, very old drug, para, previously name was there, para-aminosalicylic acid, very many, as it is salicylic acid, a big dose is there in grams, so not well tolerated. Then here you see capreomycin, it is like aminoglycosides. Then ciprofloxacin. You might have studied ciprofloxacin among the new groups. Fluoroquinolones, what you studied there in quinolones. One word is quinolines and these are quinolones. Ciprofloxacin, antibiotic now used for various other diseases. Clofazimine, cycloserine, ethionamide. Ethionamide is like pyrazinamide, isoniazid. Then levofloxacin. Upper one is Cipro and over its sister is levoflox. Then rifabutin. It is sister of this rifampin, rifabutin. It has some advantages over the previous one. Rifapentin, like this, rifampin. Original rifampicin obtained from streptomycin mediterranean. That was the first kind of, this was one type of classification previously you have gone through. There may be classification like antibiotics and non-antibiotics. Antibiotics you should also see from some literature, and there are medicines which are antibiotic while the others they are non-antibiotics and used in tuberculosis. Here you see the MDR in this very multi-drug resistant tuberculosis. Multi-drug resistant tuberculosis. So it is written over here that two or more agents in combination should be used to treat active TB to prevent emergence of resistance. You've been given about it already. These are it's a duration. You have been told that the minimum duration is say 6 months, then 9 months, and it may even go up to 18 months. Here you see regimen and approximate order of preference. A doctor has to decide. Here you see first regimen. It's a combination of isoniazid, rifampin, pyrazinamide given for 6 months. Then another one is isoniazid, rifampin, 9 months. You are giving it for a very longer period. You must monitor the toxicity. You have to assess the patient. Then other one is rifampin, ethambutol, pyrazinamide. This regimen for 6 months. The next one is rifampin and ethambutol, just for 1 year. Then isoniazid. This isoniazid and rifampin may be used in certain conditions as sole agent. So one has to be very careful to avoid resistance. Here you see the rifampin, ethambutol for 12 months. Then if the isoniazid and ethambutol, it is 18 months. Here near the lowest one you see even for more than 2 years. Relapses are common and the disease may go dormant next. First line anti-tuberculosis drugs. Over here, isoniazid, you've been told that discovered in USA, known as it is the most active drug for tuberculosis, written over here. Most active drug for tuberculosis, isoniazid. You might have heard about this drug. They are in your biochemistry as acetylation related to. People are slow acetylator, people are rapid acetylator, and the dose is to be adjusted accordingly. This isoniazid, you've been told that it's a hydrazide of isonicotinic acid, pyridoxine. It is water soluble. The drug structure resembles that of pyridoxine. When this drug is given for a longer period, peripheral neuritis is a big problem. So for the reason, this pyridoxine, you know this vitamin, probably B3, I hope it is B3, if I'm not wrong. Then isoniazid and pyridoxine, it is added to this regimen to avoid that peripheral neuritis. And then isoniazid, it has good penetration into macrophages, and this drug is bactericidal. Luckily, this drug is bactericidal. You have been told earlier that bactericidal drugs, they are preferred over the bacteriostatic. Note it down again. Bactericidal drugs, they are preferred over the bacteriostatic. This bactericidal effect is especially for the rapidly multiplying or actively multiplying bacteria. The drug isoniazid is active against both extracellular and intracellular organisms. Intracellular and extracellular. This is the structure and it has resemblance. Note it down. Isoniazid has resemblance with the vitamin pyridoxine. About the kinetic. Drug is well absorbed GIT. Most of these drugs are well absorbed orally except the glycosides, aminoglycosides, streptomycin family. They are injected. So generally most of the drugs they are well absorbed from and they have wide distribution, mind it. Usually they have wide distribution. Readily distributes to tissues and body fluids. It's in oral preparation and also parenteral, it is written, then metabolized by the acetyl and acetyl transferase. You have been told about it. There is acetylation and it is genetically determined. Genes are related to these enzymes production and the resistance development. Over here, this isoniazid, it is metabolized by acetyl transferase and rapid acetylators. It is metabolized in 1 hour, while in slow acetylators, it takes time around 3 hours. Main excretion written over is in urine. Then, how it acts. Here you see some changes. There is CAT gene, CAT G, bioactivation. A CAT G, it is gene. So Mycobacterial catalase peroxidase. By this gene, Mycobacterial catalase peroxidase is produced, so the drug is bioactivated. What it does, the isoniazid, INH, abbreviation is INH. The mycolic acid synthesis that is inhibited, which is an essential part of the tubercle bacilli wall. So the drug kills the cell. Here you see one reaction is shown over here by CAT G, isoniazid. It is activated. So it has got killing effect so on the bacterial wall. Here you see at the lower level liporabinomen. My first is in the wall of bacterial wall is mycolic acid, then rabinogalactan, then peptidoglycan. Some drugs, one of these drugs that will act on the rabinogalactan. This drug isoniazid is working on mycolic acid synthesis. So this picture be drawn by you. So coming to the next one. How the resistance develops. There is deletion in the CAT G gene. CAT G gene is deleted. That calls for the production of catalase peroxidase. This catalase peroxidase also acts on the hydrogen peroxide high level resistance. Main reason of the resistance, and there is deletion in the CAT G gene of the bacteria. Then low level resistance, second one, there is deletion in the isoniazid INH A gene that encodes the target enzyme. and acyl carrier protein reductase. Acyl carrier protein reductase. Difficult to remember, anyway you have to write it. It's a low level resistant weapon. And another reason of the resistance, there is overexpression of gene involved in protection from oxidative stress. Very important. To avoid oxidative stress, there is overexpression of gene involved. Then another way of this resistance is the mutation in Cas. Mutation in the genetic formation of the that bacteria changes there, they will occur, and so the resistance, that's a big problem that develops. Clinical uses, here you see written, although it is written over here, for latent tuberculosis as a single agent given for a very longer period, and in combination with second agent, even 3-4 drugs are given at a time if this uses. Toxicity of isoniazid, well studies. One overall immunologic reactions may be fever, skin rashes, and drug SLE. What is SLE? You have to write. SLE may be. Then there is direct toxicity of this isoniazid, especially on the nerve. Peripheral neuritis, not seen, yes, at second line, it is there. So there may be hepatitis. So you have to assess the liver function. Then peripheral neuropathy is a big problem. Yes, this was B6 deficiency. Paradoxin, it was not 3, B6 deficiency. That is to be given side by side. So relative B6 isoniazid promotes its excretion. Please do this correction, and this paradoxin neuropathy, you have to add B6. Kindly note it down, please, not B3. Then CNS toxicity. Isoniazid, some of the drugs like it, they have got stimulant effect on the higher centers. So euphoria may be there. Over here, CNS toxicity, memory loss, psychosis, euphoria, even there may be conversion, seizures. Then blood disorder may be there, pyridoxine deficiency, already you haven't told, then tinnitus, and maybe GIT disturbance. Main are the peripheral neuropathy, hepatitis, CNS toxicity, and what have you to do. Interaction, very important. You have been told that whenever some drug is inhibiting or it is stimulating this cytochrome P450 system, so the level of other drugs, if given side by side, it must be monitored. So it's an inhibitor of cytochrome P450, so the phenytoin level that will increase. So one must be careful in. See, when not to be given this isoniazid, it is the development contraindication. If there is hepatitis, so you have to avoid it. And this hepatitis risk, it increases with age, increases with pregnancy. You know most of the drugs. they are avoided in pregnancy and also in postpartum period and in alcoholics. Contraindications, one has to be very careful while giving isoniazid in such. Our next slide, it will be covered later on by your next teacher, inshallah. So nice of you. Have a good day. Thank you very much. खुदा हाफिज।